Today's speaker is Dr. Carla Abdelnour. Dr. Abdelnour is a neurologist, a researcher. She has a passion for advancing our understanding of Lewy body disease. Her work focuses on exploring the intricate relationships between co-pathologies and their influence on clinical presentation, cognitive profile, and progression of this neurodegenerative condition. Additionally, she aims to shed light on the underlying biological mechanisms of prodromal Lewy body disease. I was not going to say that word because I don't know what it means, with a particular emphasis on identifying potential biomarkers for more accurate diagnosis and prognosis. Dr. Abdelnour is a postdoctoral fellow and in Dr. Poston's lab at Stanford University, and is a member of the board of directors of the Lewy Body Dementia Association. With an unwavering commitment to making a positive impact on the field of neurology, Dr. Abdelnour's optimism and professionalism drive her forward in the pursuit of solutions and advancements that hold the promise of improving the lives of individuals affected by Lewy body disease. Also, Dr. Abdelnour may mention that she is one of the investigators in a clinical study called Healthy Brain Aging Study at Stanford. And we have some flyers on the table at the back of the church. Our Mark Alexander has participated in this study for the last 5 years and is around to answer questions about it. Dr. Abdelnour, thanks so much for joining us today.
Thank you very much for the kind invitation and for the presentation. Well, again, thank you very much for the invitation to talk about cognition in Parkinson's disease. It's an honor for me to share with you some of the knowledge that I have as a neurologist and as a researcher, because I think that we need to spread the word about the different symptoms that patients with Parkinson's disease might have. And usually we focus more on the motor symptoms, but as you know, this is not the only symptoms that patients present. So today I'm going to talk mainly about cognition. And as you heard from the presentation of my profile, I specialize in Lewy body disease, and I'll explain with all of these terminologies that I'm now telling you. Okay. These are my disclosures, but they are not relevant for the presentation. So today I'm going to talk about Parkinson's disease, and I'm going to explain to you why Parkinson's disease is a type of neurodegenerative disorder called Lewy body disorder. Don't worry, because I'll explain that in a minute. I'm also going to talk about how we make the diagnosis of cognitive impairment in Lewy body disease, and what is the patient's journey of Lewy body disease patients from the neurologist perspective. But of course, I know that you are guys the experts, the patients and the caregivers are the experts on the journey. I just want to share with you some of the things that we see as specialists. Okay, so let's start with Parkinson's disease. It's a type of Lewy body disorder. Let's start. What do I mean when I say Lewy body disease? So Lewy body disease is a neurodegenerative disorder, and the word neurodegeneration means that the neurons, those are the cells in the brain, start dying for a particular reason. And I'm going to show you a slide that is a little bit complex, but bear with me. So don't freak out. But this is the way that we classify neurodegenerative disorders. And as you can see, it's very complex, because what we think right now, what happens in Parkinson's disease and Alzheimer's disease and other neurodegenerative disorders, is that there is an abnormal deposition of proteins, and proteins are substances that we have in different parts of our body. But for a reason that we don't understand, these proteins start depositing in the neurons, and in the case of Lewy body disease, this deposition leads to the death of neurons. So there are different proteins that can deposit in the brain, and the one that deposits in the Lewy body diseases is a protein called alpha-synuclein. So I'm sure that was a very complex slide, but yeah, it's a little bit of a complex issue that we're dealing with. So now I'm going to explain why we call this disease Lewy body. And the reason why we call the disease Lewy bodies is because when we see the brain under the microscope, we are able to identify these depositions of the protein that I told you about inside of the neuron. So this round circle that you see here, this is a neuron here, and this round body that we see here, that's a Lewy body. And it's called Lewy body because the doctor that was the first describing these deposits was called Frederick Lewy. So that's why we call them Lewy bodies. So when we see patients with Parkinson's disease and another disease called dementia with Lewy bodies, if we see the brain of these patients under the microscope, we will find these Lewy bodies inside of the neurons, and also outside sometimes of the neurons, and these are called Lewy neurites. So that's why we call Lewy body disease, because there are these deposits of Lewy bodies inside the neurons. And there are two diseases that have this characteristic. Parkinson's disease have Lewy bodies in neurons, and another disease called dementia with Lewy bodies. And I'll talk about a little bit of the difference and the similarities between those two diseases. Okay. Now, as I mentioned, there are two types of diseases that have Lewy bodies. These are Parkinson's disease, and then we have dementia with Lewy bodies. What happens is that patients with Parkinson's disease can develop cognitive impairment, and some of them will develop dementia, and that dementia syndrome is pretty similar to the dementia that we see in patients with dementia with Lewy bodies. And to make everything more complex, because sometimes we're not very original with the names, we call these diseases Lewy body dementias. So if a patient with Parkinson's disease develops dementia, that's a type of Lewy body dementia. And there are also patients with dementia with Lewy bodies that have this type of dementia. But this is a continuum, and we classify the patients when we see in the clinic, and when we follow them during years, we are able to see changes in different symptoms. Right now, I'm explaining only the cognitive symptoms, but all the other symptoms also can evolve and can progress. So this is not as an static disease, and our aim is to be able to identify patients in early stages of the disease. But how do we know if a patient has cognitive impairment or not? And what do we mean when we say mild cognitive impairment or dementia? I think it's very helpful to clarify the terms that we use as clinicians, because sometimes those terms could be misinterpreted by the public. So the way that we classify the presence or absence of cognitive impairment is by answering these three key questions. First, we want to know if the patient, a caregiver, or the physician has seen a complaint in cognitive functions. Then we will run tests to see if the person is able to perform according to their age, sex, and level of education. So there are different cognitive tests that we can run to identify objective deficits. And the last question that we have to answer is if this cognitive impairment affects the ability of the patient to perform activities of daily living. So there are different reasons why a person might have impaired ability to function daily. For example, a person with depression might have difficulties in doing chores or planning a trip or solving problems. But in that case, the impairment to perform activities of daily living is not from a cognitive function, it's from a behavioral issue. It's from the depression or an alteration in mood because of a mood disorder. So in that case, we won't call that cognitive impairment, or the cognitive impairment is not the reason why the person is not able to perform the activities of daily living. So when we rule out other causes that could explain cognitive impairment, usually we end up with neurodegenerative diseases, especially if the person is more than 65 years old, because this is more frequent in older people. So if a person does not have any complaint, the person maybe has, I see sometimes people say, well, I have finding word difficulties, but that's stable and that hasn't changed. Well, it seems that there is a complaint, but it's a stable complaint, so that might be normal. If the tests are normal and the person is completely independent for activities of daily living, we call that normal cognition. Now, if the person has complaints or the caregiver has complaints, so those fine wording difficulties have progressed, and now I have difficulties in keeping a conversation, or I need more time to understand what other people is saying, and I have run some tests with my neurologist, and I went to a clinical neuropsychologist, and they ran me some tests, and my scores are abnormal for my age and level of education, but that doesn't impair my ability to do activities of daily living, and I can live completely independent. That's called mild cognitive impairment. And if the cognitive impairment affects the ability of the person to perform activities of daily living, that's why we call dementia. So the issue that we have with the word dementia is that it's associated usually with Alzheimer's disease, because Alzheimer's disease is the most prevalent cause of dementia in people that is over 65 years old. But there are other causes of dementia, and actually, as I will mention in a few minutes, Lewy body disease is the second most common cause of neurodegenerative dementia. So it's not infrequent. It's just that in our mind, when we say dementia, people think immediately in Alzheimer's disease. There are different causes of dementia. Any cause of dementia that causes the patient having symptoms, the test being altered, and impair the ability to perform activities of daily living, that is dementia. And dementia have different grades. Not everybody is in the same stage. So we separate patients that have mild dementia, moderate or severe, depending on the activities that they're able to perform. Usually, in the mild stage, the patients have difficulties in performing instrumental activities. In moderate stages, what gets affected are some basic activities, so they need supervision. And in more severe stages, what gets affected is basic needs, but they are completely dependent on another person. And this is progressive. So these diseases, neurodegenerative diseases, are slow and progressive. That means that the changes that we're going to see don't appear from one day to another. If that's happening, we are going to think in another causes. For example, a stroke, or if a patient have a diagnosis of a neurodegenerative disease, and in addition is suffering from an infection, that can cause sudden deterioration. So we are going to think about a secondary cause. These diseases usually take years to develop, and the symptoms takes years to affect the abilities of the ability of the patient to perform activities of daily living. So the take-home messages from this first part is that Parkinson's disease is a neurodegenerative disorder and is a type of Lewy body disease. That we think that the cause of Lewy body diseases is the deposition of an abnormal substance in the brain called alpha-synuclein inside of a neuron, and those deposits are called Lewy bodies. That neurodegenerative diseases are slow and progressive, and this is a continuum. And this is important for us as clinicians because we want to be able to identify patients in early stages of the disease. And then when we say Lewy body disease, we mean two diseases, Parkinson and dementia with Lewy bodies. Okay. Now I'm going to explain how do we make the diagnosis of cognitive impairment in patients with Lewy body disease. And I'm saying Lewy body disease because what we use for dementia with Lewy bodies is pretty similar from what we use for Parkinson's disease. Again, I don't want to scare you, but I just wanted to show you, we have criteria for diagnose the presence of cognitive impairment. And here I'm presenting the criteria of the dementia stage because this is the one that we are using most widely in the clinic. Now, we can also we have criteria for diagnose patients with Parkinson's disease that have mild cognitive impairment. And that's why there are only two cognitive functions altered. And we can also identify if the patients with Parkinson's disease have normal cognition. What usually happens is that patients with Parkinson's disease are evaluated in movement disorder units, and we often focus on the motor symptoms. Now, some specialists, and if the patient talks about cognitive symptoms, will also make evaluations about these symptoms, and we'll be able to identify what is the stage, if the patient with Parkinson's disease have normal cognition, have mild cognitive impairment, or dementia. And this is important because patients with Parkinson's disease, when they present at the first time at the clinic, about 20% of them newly diagnosed patients with Parkinson's disease have diagnosis of at least mild cognitive impairment. So it's not a small number. Not only that, if we wait about 10 years, patients with Parkinson's disease, about 80% will develop Parkinson's disease dementia. So cognition in Parkinson's disease is frequently affected. And if we wait enough time in the course of the disease, we will see that a lot of these patients will develop dementia. And I don't want to scare you because not all patients will develop cognitive impairment or dementia, but some of them will. And this is something that we have to be cognizant because if we're able to identify that, there is treatments for these symptoms that we could use that I will talk in a minute. Now, what is the difference between dementia with Lewy bodies and Parkinson's disease dementia? Well, we doctors are using a very arbitrary rule. I have to be honest with you. And we have decided that if the motor symptoms start before the cognitive symptoms, in about 1 year before the cognitive symptoms start after the motor symptoms, we call that Parkinson's disease. So Parkinson's disease, first motor symptoms, and we wait if cognitive symptoms appear or not. But if the motor symptoms and the cognitive symptoms start close to each other within 1 year, we call that dementia with Lewy bodies. So we know this is a very arbitrary decision because every patient is different. And there are different reasons, mainly historical reasons, why we have come up with this solution. hopefully this will change in the future when we have better ways and not only using clinical criteria, but also biomarkers to be able to identify the specific stage of the patient. But this is currently helpful for trying to dissect in what stage the patient is or what type of disease, because these two diseases are a little bit different, although there are more similarities than differences. So the main message is that in patients with Parkinson's disease, what happens is the motor symptoms are more important, more frequent, or even more severe, more apparent than in patients with dementia with Lewy bodies. In dementia with Lewy bodies, what we see more are the altered cognition and other behavioral symptoms that may not appear in patients with Parkinson's disease. So in patients with Parkinson's disease that develop dementia, what we see most frequently are the motor symptoms. We see a slowness that we call bradykinesia. We also see the presence of tremor, usually it's resting tremor. We see patients with abnormal gait and posture and with stiffness. But as I mentioned before, Parkinson's disease patients also have other non-motor symptoms. So in early stages of the disease, and sometimes even before the diagnosis, we see that the patients present loss of smell, constipation, disturbances in sleep. They have sleep disorder. And there is one particular disorder that is that it makes us think about that the patient might have Parkinson's disease or could develop Parkinson's disease, and that disorder is called REM sleep behavior disorder. I'll explain that in a few slides. Next, these patients also can present sexual problems, pain disorders, and hypophonia, that's low volume while speaking. Then also early after the diagnosis, in early stages, the patients can present mood disorders like depression, apathy, or anxiety, other non-motor symptoms like urinary urgency, excessive sweating, excessive salivation, dysarthria, or dysphagia. But later on the disease is when we see the dementia and other symptoms that we call psychosis. So the term psychosis means that the person is not able to understand reality, or have a different understanding on reality, and have a misinterpretation of a stimulus. So for example, that could be hallucinations. So the person might be seeing or hearing things that are not real. And it could also be delirium. And that means that the patient have ideas that are not real. So for example, patients might think that there is someone in the house, but actually there is no one in the house. And dementia and psychosis usually present later in the progress of patients with Parkinson's disease. Other symptoms that can be present is severe orthostatic hypotension. That means that the patients present a very sudden drop of the blood pressure. They can also have urinary incontinence or more severe difficulties in swallowing, and can even have choking events. But in dementia with Lewy bodies is more complex, and it's different in the sense that the motor symptoms could be very subtle, actually. So that's the difference with Parkinson's disease patients. In Parkinson's disease, we are going to look for motor symptoms pretty early in the disease, but patients with dementia with Lewy bodies do not necessarily present these motor symptoms at all, even, or if they present it, they are very subtle. So Parkinsonism is not required. What is required is that you have at least two of these four criteria or symptoms. So Parkinsonism can't be present. It's not required. Patients also can have cognitive fluctuations, REM sleep behavior disorder, and hallucinations. And I'm going to explain a little bit in more detail, because these symptoms can also be present in patients with Parkinson's disease, and the treatment will be pretty similar. So as I mentioned before, patients with dementia with Lewy bodies might have Parkinsonism, and I'm sorry because in my slide I know that there is a lot of medical terminology. I'm trying to explain in lay terms, and if you don't understand something, I'm super happy to answer any question at the end. So as I was talking about, patients can have Parkinsonism, and the type of Parkinsonism that they present, patients with dementia with Lewy bodies, is more rigidity and slowness. It's less frequent that they actually have rest tremor. It could be present, but it's less frequent. The way that we diagnose that is with the medical history and the physical examination. It is the same one that we use for Parkinson's disease patients. And the difference with Parkinson's disease is that patients with dementia with Lewy bodies usually don't respond that good to levodopa. So for example, if we start treatment with Sinemet, sometimes they don't respond to this medication. But patients with Parkinson's disease usually have a very good response to levodopa. The other feature that we look for when diagnosis dementia with Lewy bodies is cognitive fluctuations. And that's not a requirement for patients with Parkinson's disease. And cognitive fluctuations are events where the patient suddenly zooms out, or there are periods during the day or during the week when there are off periods but in cognition. So I'm sure some of you are aware of how sometimes the motor symptoms have off periods, like the patient feel very low, ability of perform any motor task. Well, this is similar, but with cognition, is with cognitive functions, not with motor functions. And the way that we diagnose this is with the interview, but this is very difficult to identify because it's not apparent for a lot of patients. And when it's apparent, it's super easy, but it's actually very difficult to identify because there are other diseases that also cause this. So patients with Alzheimer's disease can also have cognitive fluctuations. And there are not a lot of studies treatments trying to tackle the specific symptoms, but the few studies that are available have shown that some drugs that we call acetylcholinesterase inhibitors can help with these symptoms. Also, memantine is another treatment that we use. I mentioned this sleep disorder called REM sleep behavior disorder. And when this disorder is present in a person that doesn't have the diagnosis of Parkinson's disease or dementia with Lewy bodies, we follow these patients because some of them have increased risk of developing this type of neurodegenerative diseases. And the REM sleep behavior disorder is a type of parasomnia where patients act out or talk during the dream. And this is abnormal because when we are sleeping, we should be completely paralyzed. But the issue here is that the centers that control the movement during the sleep are altered. They don't function correctly. So the things that you are dreaming about, you start moving as if you were awake. And the way that we can diagnose this is with the medical history. Usually for this, we need a bed partner. So people that sleep alone, there is more difficulties in diagnosing this. But when there is a bed partner, usually the bed partner is the one that is able to say, yes, my husband or my wife is talking or punching or kicking, and some bed partners even can be injured. So this is important because depending on the severity of the symptoms, there are some treatments that are pretty good. So usually melatonin or clonazepam are very good for treating this symptom, and that prevents the injuries for the bed partner, or even sometimes the patients, because the patients can fall from the bed. So this is a very important symptom to follow up. And the other feature that is present and is very characteristic of patients with dementia with Lewy bodies is visual hallucinations. So this is the perceptions of things that are not there. And typically aware form, and what people describe, that patients describe, is that they see people, children, or animals. And sometimes it can be other types of hallucinations that we call minor hallucinations, like passage or sense of presence. So for example, patients said that they feel that they have somebody behind them, and when they look back, there is no one there, or they feel like a shadow passes by. So these are minor hallucinations. And what is also typical is that patients usually have a lot of insight. They know that what they are seeing is not real. These hallucinations are more frequent in low light conditions, so they are more frequent in the night. And patients say, well, it's just I wake up in the night, I see this, but I turn on the light and the little kid that was in my bedroom disappears. So this is pretty frequent, and they don't are usually they're not afraid of this because they know that is not real. And some patients with Parkinson's disease can also have hallucinations, and you often ask this during the medical history. There are also questionnaires available, and we ask this because in patients with Parkinson's disease, this could be a sign of the medication being too high. So sometimes if the dose of the levodopa that we are using is a little bit high for that patient, they might have hallucination, and that's an indication that we have to make adjustment to the dosage. So this is why we always ask about hallucinations, because in patients with Parkinson's disease could be due to the medication, could be part of the progression of the disease, and in patients with dementia with Lewy bodies is pretty typical. And for that, what we usually try to do is, depending on how the patient is affected about the hallucination, we will treat them or not. Because if the patient knows that what he or she is seeing is not real and it doesn't cause a lot of stress, it's not necessary to use drugs in this case. Sometimes what is more disturbing, it could be for the family members, because hallucinations are pretty scary. But what we do is we explain what is happening, and if the patient explains what is happening, and we also can do some non-pharmacological suggestions. So for example, trying to keep a light on during the night, like on the bedside table, that could help. So, but if the hallucinations are not troublesome for the patient, we will try to avoid medication. And the reason that we will try to avoid the medication is because the treatments that are available for treating psychosis usually can worsen other symptoms. So the antipsychotics in patients with dementia with Lewy bodies can cause more Parkinsonism, falls, and are associated with increased risk of vascular diseases. So we will try to avoid them as much as possible. But if the hallucinations are pretty troublesome, we will use very low dose of quetiapine. Sometimes the cholinesterase inhibitors are very good too, and we will use them off-label. And for patients with Parkinson's disease, recently there has been a drug approved called pimavanserin. So that's another one that we can use if necessary. Dementia with Lewy bodies can be diagnosed with the aid of biomarkers, not only with the clinical symptoms. And there are several tools that are available if we have doubts about the diagnosis. One of those biomarkers is called DAT scan, and the DAT scan is a CT scan of the brain that we will use to see the basal ganglia. So the basal ganglia is a part of the brain where the involuntary movements that we perform are controlled. So hopefully you see my mouse here. And when we do a DAT scan, what we do is we inject a tracer that is like a type of contrast that goes to the brain. And we will see that a part of the brain have reduced intake of this tracer or not. And if that tracer is reduced in some part of the brain, in this case the basal ganglia, we will think about dementia with Lewy bodies. But this can also be altered in patients with Parkinson's disease. So this biomarker doesn't help for differentiating these two diseases. The only thing that is telling us is that the neurons that are in this part of the brain, the number of neurons is decreased. So there is less neurons producing dopamine in that part of the brain. Another test that we can perform is imaging of the heart. So the heart is innervated by the sympathetic and parasympathetic system. So it's those systems work in balance to maintain the heart rate and the blood pressure. And what happens in patients with Lewy body, with dementia with Lewy bodies, is that the heart has less sympathetic innervation. So we will see this decrease of uptake in the heart in patients with dementia with Lewy bodies. And the other thing that we can do is confirm the suspicion of REM sleep behavior disorder with a sleep study. So what we do during a sleep study that we call polysomnography is we perform an electroencephalogram of patients during the night. We also put EMG electromyogram to assess the muscular function, and we record the electrical signals from the electroencephalogram and electromyogram, and with that information we can see if the patient have periods of REM sleep without atonia. That means that the patient is dreaming but is acting during the dreams, that is not paralyzed. The other thing that we do for diagnosing patients with Parkinson's disease and dementia with Lewy body is to assess the cognitive functions. So the way that we classify the cognitive function, that is also an academic classification, is in executive function, visuospatial, memory, language, attention, and working memory. So our brain and these functions, they are all correlated, they are all associated, but there are specific parts of the brain that are more specialized from one cognitive function than others. So this classification is helpful for letting us know where in the brain could be the potential damage of the neurons. So patients with Parkinson's disease that have cognitive impairment usually have what we call dysexecutive function. They have problems with planning, with problem solving. They need more time to process information. They have troubles with abstract reasoning, or with understanding complex problems. And these all are, we call them executive functions. So for example, a patient might say that have difficulties in planning a vacation, or filling taxes, or following a recipe. And all those tasks were done before without any issue. And there are different tests that we can use to assess this. Also, patients with Parkinson's disease often have visuospatial dysfunction. And in this case, the difficulties is in trying to identify or calculate the three-dimensional space. So there could be issues with driving, or calculating the space when you need to park, or writing. Sometimes they can have difficulties in understanding how to follow lines. So these are the types of symptoms that we will see in these patients. Also, patients with Parkinson's disease can have problems with attention or working memory. And attention and working memory is what we need to focus in a task during a small period of time. So they will have difficulties, for example, in reading a book or following quick instructions, or if we say something information that you need to use in the following seconds, they have difficulties in retaining that information because of inattention. And as you can see, attention and memory are very correlated, and they are associated because you need to pay attention to be able to remember. So memory could be also be affected in patients with Parkinson's disease, but it's not as frequent as, for example, when we compare them with patients with Alzheimer's disease. So in Alzheimer's disease, what we see typically is an alteration of short-term memory, and patients have difficulties in learning new information. Now, patients with Parkinson's disease can also have difficulties in learning new information, but if we give a cue, the patient is able to remember the information. So the information was stored, but the difficulty is in finding it. So if we give a cue, we help the patient. And that's a little bit of a difference that we see in patients with Alzheimer's disease. If we give cues to patients with Alzheimer's disease, they often don't remember the information because the information was never stored in the first place. So in conclusion, memory can be impaired, but it's not as frequent, and there are some subtle differences in the type of memory impairment that we see in patients with Parkinson's disease and Alzheimer's disease. And in terms of language, usually patients with Parkinson's disease don't have problems with language, and defining word difficulties, sometimes we classify that as an executive function, actually not as language. So when we say language, we mean if we're able to understand and produce language. And usually they understand pretty good the conversations, and they don't have issues with following a conversation. And so some specialists and some neuropsychologists classify finding word difficulties as language and others not. But in any case, the ability to understand language is usually preserved. And in patients with Alzheimer's disease, that could be usually impaired. So this is another difference that we see in these two neurodegenerative diseases. So the medications that are available for cognition that we use in patients with Parkinson's disease were originally developed for Alzheimer's disease. So these medications, what happens is that there have been studies performed, some of them are clinical trials, using drugs for Alzheimer's disease in patients with Parkinson's disease. And these drugs that are available are called cholinesterase inhibitors. There are 3, donepezil, rivastigmine, and galantamine. And the ones that have more information, and I think in my experience as a clinician, patients respond better, are rivastigmine and donepezil. So I did my residency in Spain, and I usually will use rivastigmine, the rivastigmine patch, because it's more convenient for patients and the caregivers, and they respond pretty well to this medication. I am aware here that donepezil is often used, and patients also respond very well to donepezil. So we will see that the cognitive impairment can improve a little bit. It's not a huge difference, but what we see in the clinical trials is that the difference on the patients that receive the treatment, when we compare them with the patients that don't receive the treatment, those symptoms are slower in progression. The progression is a little bit slower than if you don't receive any treatment. And the other treatment that is available is memantine. And memantine, the studies in memantine have shown mixed results. So I can say 100% that memantine works. I think from some patients work, for some other patients don't work that well. So I guess it depends on each patient. So the take-home messages for the part 2 is that dementia with Lewy bodies and Parkinson's disease dementia are pretty similar, and the difference that we use in the clinic to diagnose one or the other is what symptom occurred first. If the first symptom is cognitive, we will call that dementia with Lewy bodies. But if the first symptom was motor, we will call that Parkinson's disease dementia. It's important to keep in mind that patients with Parkinson's disease can have motor and non-motor symptoms, and we have to look for them as clinicians. And that the diagnosis of dementia with Lewy bodies include not only clinical symptoms, but also can be supported by the presence of biomarkers. So what is the Lewy body disease patient's journey? And I'm going to talk about my perspective as a clinician. So first, I want to talk about why it's important to diagnose patients. I think I mentioned before this. This is not infrequent. This is the second most common neurodegenerative disease. But the issue is that it's often underdiagnosed. And patients with Parkinson's disease often experience that cognitive or behavioral symptoms are not addressed during the consult. And this is an issue because patients with Lewy body disease have worse health indicators that when we compare them, for example, with patients with Alzheimer's disease. So they often have higher mortality, higher functional impairment, higher impact in quality of life, higher healthcare costs, earlier nursing home admission, and higher rates of hospitalization. So it's really important for us to diagnose this patient, and it would be ideal if we are able to diagnose them early in the disease process. And the problem that we have in the clinic is that it's difficult to diagnose because I showed you this slide before, which is super scary. The thing is that these proteins that I show you often interact. So usually the history is not that simple, and you can have not one, but 2 or 3 or more proteins deposited in the brain. And when you have more proteins, abnormal deposits of proteins in the brain, that can change the phenotype or the symptoms that we see in the clinic. So patients with Lewy body disease often have what we call copathologies, or the presence of other proteins in addition to alpha-synuclein. And the pure cases of patients with Parkinson's disease, for example, are only 10 or 20, maybe a little bit more if they have normal cognition. But quite often when a patient with Parkinson's disease have abnormal cognition, they will have, with a high probability, another protein in the brain. So patients with Lewy body disease, when we see the brains at autopsy, approximately 50% can also have the proteins that are deposited in Alzheimer's, and 30% of them can have vascular disease. So the issue is that this is a more complex issue that we thought at the beginning, and that changed not only the clinical presentation, but probably also the response to medication. So what we need to do is to be able to diagnose these patients with new biomarkers. And sometimes these biomarkers can be assessed in CSF, the cerebrospinal fluid, that is a liquid that surrounds our brain and our spinal cord. There are new biomarkers in blood that are being developed and in the skin, but often these biomarkers are currently under research and not available, all of them, for diagnosis. But we are moving towards making that possible, making these biomarkers available to be able to identify these proteins in tissue or in blood samples or other body fluids, so we can diagnose patients more objectively. And the things that we can do for our patients is know what the problem is, treat other conditions, start the treatments for the symptoms, support our patients, and also encourage patients and caregivers to participate in research. In terms of knowing what the problem is, I think that one of the most important parts is to encourage patients to go under neuropsychological testing, because that will help us understand how the person is doing in the different cognitive functions, And this is something that needs to be done longitudinally with one only assessment at the beginning that gives us information, but actually what is more helpful is to see the progress in the different cognitive functions. This is going to give us more information about what is the progression of the patient. Also, we have to be aware that people with Parkinson's disease often have other comorbidities. And we have to be aware of that because some of the medications for those comorbidities can have side effects or can interact with the Parkinson medication. We have to check for the presence of infection. We have to measure thyroid function or vitamin 12 levels. You have to evaluate for the presence of mood disorders, treat dehydration if it's present, or orthostatic hypotension. Consider treating obstructive sleep apnea or insomnia, also correcting hearing loss, visual changes, or cataracts is important because sometimes that can affect your ability to perform cognitive functions, actually. So if we are able to put hearing aids in a person that have difficulties in following a conversation, that can be transforming. And also we have to encourage exercise and social engagement. In terms of support, I think it's important, of course, the work that you do as a support group. And I think it was very moving to hear, and I completely agree that it's good for you to meet with other people that are experiencing the same situation, because that will help you cope with the disease and learn other strategies that other people develop and share that knowledge. I think that's very important. I think we also have to encourage end-of-life discussions, especially early in the disease. And I know that sometimes that could be tricky because there is a lot of stigma around those issues, but we have to be aware that at the beginning of the disease, the patient is able to make decisions and usually don't have cognitive impairment if that's the case. So it's better to be aware of that and respect the patient's decision in these matters. And also, it's good to consider palliative care consultation. In terms of participation in research, I'm particularly involved in them. I'm biased here. I'm going to be completely honest with you. I think it's super important that patients and caregivers participate in research because you are the experts on the disease. We are specialists and we study these diseases from the lens of neurologists or researchers, but you are the ones living with the disease every day, and we need to learn from you. What are the things that we have to look for? So I think together we make a good team to find solutions, because I think what we want in the future is to be able to cure these diseases, to find treatments that are so good that we can hold these diseases finally. But we are only going to get there if people is able to participate in research studies, because we need to gather a lot of data, not only biological, but also epidemiological data or clinical trials data to know what's working and what is not working, what are the variables that are most important. So in particular here at Stanford, I'm going to explain 3 studies, and Mark also is participating in one of these studies. One of the studies that we're doing is a imaging study where we perform a PET scan to analyze a protein called tau in the brain. Another one that we're doing is studying the microbiome in patients with Parkinson's disease. And here, what we want to understand is what is in the interaction between the microbes that live in our gastrointestinal tract with the development of Parkinson's disease. And finally, the study that Mark is participating is the Healthy Brain Aging Project. And we are an Alzheimer's Disease Research Center, but in our study, we're also including patients with Parkinson's disease, and we perform a very extensive recollection of data from the personal history. We perform neuropsychological testing, and we provide the patient with the option of also participating in an amyloid PET study, tau PET study, CSF study, and blood sampling. So the take-home message for this last part is that Lewy body disease is not uncommon. That is the second most common cause of neurodegenerative diseases that is often under or misdiagnosed, and that delays the access of patients to proper management. That the diagnosis is difficult because these diseases usually are not pure diseases. There are more proteins deposited, and that changes the clinical characteristics. Also, there is lack of disease-specific biomarkers, but we are working in that, and hopefully we will have a good news in the future for this. And to help patients with Lewy body dementia, I think that we need to know what the problem is, trying to understand the cognitive characteristics of each patient and the progression of the cognitive symptoms, treat other conditions, start pharmacological treatment if that's needed, and also provide a specialized support. And with that, I think, oh my God, I'm okay in time, great. So I'm happy to take any question.
Anybody in the room have questions?
I have a question.
Mm-hmm.
So I'm just wondering, you showed a slide where you indicated some Lewy bodies going into a cell, and is that possible to detect that movement, or is that in a part of the brain that isn't accessible?
That's a great question. So the Lewy bodies that deposit inside the neuron come from a protein called alpha-synuclein. And we all have that protein normally. That protein works as a facilitator of the communication between neurons. What happens is that this protein is transformed abnormally and start depositing inside the neuron. It's like the neuron has trash in it.
Mm-hmm.
But this protein usually has a normal configuration. So it's only when the neuron loses the normal configuration when it starts deposited inside the neuron. And this happens in a part of the brain that we call the brainstem in patients with Parkinson disease. And we think that from the brainstem, that deposition starts to occur in other parts of the brain. And we think, but this is our hypothesis, this hasn't been proved completely, that part of these proteins that have abnormal configuration are also outside the neuron. So if another neuron that is healthy picks up this abnormal neuron, the protein that this healthy neuron has inside can also misconfigure it. It will misfold, and the process will start also with the abnormal deposition inside this neuron that was healthy. So it's like the neuron catch a virus and then gets also the disease, something like that. And we call that the prion-like progress or evolution of the disease. But these are all hypotheses. We haven't been able to prove that. And the issue is that, and you mentioned correctly, it's very difficult to see this in the brain. And it's difficult, one, because we don't have the technology yet to see these proteins in the brain, because the amount or the concentration of the protein is very, very small. So currently we are working in developing PET tracers, that is positron emission tomography scans, where we inject a radio tracer that goes to the abnormal protein and tag that in the brain, and we are able to see in which part of the brain that proteins are depositing abnormally. But it's very difficult because the amount is very small. So we are working in that. I think in the following years, we will be able to have a PET tracer to see that abnormal protein in a scan. Now, we can see the abnormal protein not in the exact brain anatomy, like in the location inside the brain, but we can see the abnormal protein in the cerebrospinal fluid. So we perform a lumbar puncture. That's a standard procedure that we usually do in neurology for different diseases. So for example, patients with multiple sclerosis, or if we suspect infection of the central nervous system, we perform a lumbar puncture. We take cerebrospinal fluid, that is a liquid that surrounds the brain and the spinal cord. We don't touch the spinal cord because this is we do this procedure in a part of the nervous system where the spinal cord has finished. It's only nerves there. We take this liquid and we analyze that in the laboratory, and we are able to see if there is a presence of that abnormal protein or not. This assessment could be done in the clinic if the specialist has the suspicion on what could be the diagnosis of the patient. So it can help to rule in or rule out different diseases. So that is available in the clinic, but usually is used in research.
I have another, could I follow up that question?
Yes.
So I was just thinking about getting this diagnosed, and if it doesn't sound like it's so easy to do with images, but what about the various cognitive tests? Is that something that you use for Lewy body?
Yes, so that's a great question. Yeah, with cognitive tests, we are able to get a profile of the different cognitive functions that might be altered. So the way that we do the diagnosis usually is by putting together a lot of pieces of a puzzle. Think about these diseases as being a puzzle, and we get different pieces from the history, from the symptoms, from the progression of the symptoms, from the caregiver, from the cognitive testing that also give us information, and from biomarkers. So for example, we also ask for tests and we see the thyroid function, we see the B12 levels. We try to rule out other causes that might explain the cognitive symptoms. We can ask for an MRI, for example, to see if there is vascular disease present or not, or if there is a tumor. So the thing is that there are a lot of diseases that can cause cognitive impairment. So sometimes I feel myself as a detective. I'm trying to look for all these signs and all these pieces to put all the things together and have a clearer image of what is happening with the patient. But yeah, cognitive testing can help. It's one of the pieces of the puzzle, but it's not the only thing that we use for the diagnosis.
So I was actually thinking about tests that they administer in the office, like a cognitive test.
Yeah, the cognitive tests that we use in the office can help us. Is more information, but it won't be the only thing that we will use.
Right, okay. So, and which of those tests are particularly helpful to you? I know there are many different kinds.
Yeah, that's a great question because there are lots of tests. I will like to see a lot of, at least one per cognitive function, at least one, if possible. But I'm a little bit spoiled because I have worked in centers that have that information. But I understand that it's difficult. It's not easy to, and patients get tired, and not all the centers have that capacity. So if I were to use some tests, I think there are very good screening tests. So for example, the MOCA, the Montreal Cognitive Assessment.
I've taken that test.
Yeah, that gives a lot of information. And it's not only about the score, like the mini-mental, that's another screening test, is how the patient performed the test. That gives a lot of information. So I like the MOCA better for patients with Parkinson's disease. And there are other tests like the thread-making A and B. There are tests for memory. So for example, we have a word list and we give the word list to the participant, the patient, and we ask the list of the words after a few minutes, and that gives us a lot of information. So I will, for patients with Parkinson's disease, at least I will perform the MOCA, and if possible, I will perform some memory tests in addition to another executive function test like the Trail-Making test.
Okay.
Thank
Thank
you.
you very much.
Dr. Abdelnour, we have time for 2 questions. So there's one here in the room.
Yes.
Oh, doctor, are you aware of the use of mushrooms like lion's mane for the purpose of improving cognition?
Well, that's a good question. I'm not aware of that. And I recently performed a systematic review on clinical trials. So probably what happens with some of these studies is that they need to be registered for us, the researchers, sometimes to see the study. And there are different guidelines on how to register the studies and how to also communicate the results and the protocol of the study. So I'm not aware of that one. And I recently performed a systematic review in a clinical trials in dementia with Lewy bodies. And I also read a paper about clinical trials in Parkinson's disease, and I haven't seen that one.
Okay, thank you. Alice online, unmute yourself. You need to unmute yourself.
Does everyone who has Parkinson's have Lewy bodies?
That's a great question, Alice. We have a lot of discussion about that question right now, actually. This is a very hot topic in the field. Does all the patients with Parkinson's disease have Lewy body? My answer is a quick answer. I know it's more complicated, and it's no. Not all patients with Parkinson's disease, the way that we define them clinically, have Lewy bodies. And that's very interesting because there is a very small number of patients, approximately 10% or less, that don't have Lewy bodies, and they are carriers of a mutation in a gene that we call LRRK2. And we don't understand why patients that have this mutation, that are LRRK2 carriers, don't develop Lewy bodies, but they have the dopaminergic deficit. They have less neurons that produce dopamine. So that's why they have the clinical symptoms of a patient with Parkinson's disease. So clinically, we are not able to differentiate if the patient have Lewy bodies or not. Like we can see just from the symptoms and the physical examination if the person is a LRRK2 mutation carrier and don't have Lewy bodies. But we can perform tests, genetic tests, to know if the patient have a LRRK2 mutation or not. And we are now able to perform the cerebrospinal fluid test to know if the alpha-synuclein, that is the protein that deposits in the Lewy bodies, if the alpha-synuclein is abnormal or not in the cerebrospinal fluid. Because if the alpha-synuclein is abnormal in cerebrospinal fluid, that means that with high confidence, approximately 90% confidence, that person has Lewy bodies in the brain.
Dr. Abdelnour, thank you so much for your time. And we appreciate it very, very much that you have been here for us.
Sure, you're welcome. I'm very happy to explain these concepts to you. I always enjoy very much giving this talk, and I congratulate you for all the work that you're doing.
Thank you
Question?
so much.
Can you hear me?
Yes, I think there is another question. I'm not sure if there is.
I have a question, and that is for myself. I'm going to be starting my seventh year for being diagnosed for Parkinson's, and I visit with the neurologist once a year, and we talk about some things, and he has me do the finger thing and all that kind of stuff, and walking a little bit. But nothing's ever mentioned about, well, is there any kind of tests that you should be having done as you steadily go along. And so you're told that your situation is progressing. And the thought goes through my mind, especially today after hearing what's been presented, is the fact of is there, like for diabetics and for other kinds of situations, we have, we're going to be checking you for this, checking you for that, or blood tests and that sort of thing. And I don't know of anything other than what we've just briefly talked about today. But that isn't said anything when I have my visits with my neurologist.
Yeah, I think that's a very good question. I will try to be brief in case, so the way that we follow the progression of the disease right now in the clinic is with the examination. So that's probably why the neurologists perform this motor test, because we get a score, and with that score we can compare that with the previous year, and depending on the score we can know the progression of the disease and the response to the medication. Another way to see that in the clinic is with the cognitive test. So if you have cognitive symptoms, that is something that can be mentioned to the neurologist, and that can prompt the evaluation of cognitive symptoms. And if we perform the neuropsychological test during follow-up, we can also see the progression of the cognitive symptoms, and that gives us information. What we don't have right now is a biomarker in blood, like for example, for diabetes, to know if the disease is progressing or not. And we are working on that. And that's one of my focuses of my research, actually, is to try to find biomarkers that tells us more about the progression of the disease and the stage of the patient in that specific moment, because that will be crucial also for developing treatment. So we want objective biomarkers that tell us that the person is responding to know the treatment, not only clinical assessment.
Thank you so much. Really
You're
appreciate
welcome.
your time.